Hi, I'm Bridget Hartman DeCenzo. Welcome to Learning Thursdays. A goal of Learning Thursdays is to support and help advance the educational and professional competency development of the treatment, prevention, and recovery workforce, a competency being comprised of the knowledge, skills, and attitudes relative to a task. In part, we do this by offering monthly presentations that highlight content and topics that are current and relevant. Our presentation today is a part of the Year of Ethics series. In preparation for the presentation, we requested submissions about ethical dilemmas from the field. In response, Rob Kent, our General Counsel, and Maria Pasceri, Director of State-Operated Addiction Treatment Centers, will discuss the dilemmas that were submitted. As always, if you have any questions, you can reach out to us via learningthurs@oasas.ny.gov.
Good afternoon, everyone. I'm very excited to be here with my colleague, Rob Kent, Chief Counsel for OASAS. We have an excellent opportunity today to answer specific questions that have come from the field regarding ethical concerns in doing our everyday work in dealing with patients in New York State. I wanted to start off, though, by talking a little bit about Learning Thursdays, as Learning Thursdays has had a year in ethics, which has been our theme. And each month we are providing a topic of an ethical concern that we're hoping that you will be able to get a lot of your questions answered. Each month there's a PowerPoint presentation along with references, and the references can help you do some further digging in terms of specifics with regards to ethical dilemmas that happen at your agency. And I want to say that most of the questions could probably be answered by attending those Learning Thursdays. So I really encourage you to do that, and also you'll have a PowerPoint then so that you can refer back to when sometimes those questions arise again. The other thing that I'd like to encourage you to do is purchase a book. It's reasonable. It's called Preventing Boundary Violations in Clinical Practice. The author is Thomas Guthiel and Archie Brodsky, and it was copyrighted in 2011. To me, this was a basis and primer for all the work that we did on each month in terms of the ethics topics. So I just wanted to start off by providing you those resources and hoping that you will take advantage of them. We're going to handle today's topics in topic form and then ask some of the questions that you have provided us. So we're going to start with confidentiality, as there were a lot of questions with confidentiality, and many of which had to do with dealing with legal entities. So it's good to be with you today, Rob. And I'm going to start with the first question. And it says, oftentimes counselors get requests from attorneys for information regarding their family court cases. These come in the form of subpoenas, but are not signed by a judge. They generally come from other parties, attorneys, and therefore no release has been signed. Counselors become concerned that they may be held in contempt if they do not respond. 3 questions. Do we respond to a subpoena if it's not signed by a judge? If we show up to court and get called to the stand, can we take the 5th? And if the judge releases us by court order, are we allowed to testify even if we don't have permission from our client?
Okay, so those are all good questions. First, I'd be remiss if I didn't acknowledge Tricia Allen, who should be here in my stead, but actually just had her baby last week, so she's on maternity leave. So we had scripted this out. But to answer those questions, so first, you know, you need a signed court order, no ifs, ands, or buts, or the patient's consent. And without those, a subpoena doesn't suffice. And there's documentation, there's information that we've made available on our website, so I would encourage people to look at particularly the legal section of the website that speaks to some of these issues. The other thing is my staff is fully versed on these issues. You can reach out should you be in that type of crisis situation to get information. So that's the answer to the first question. The second, with regard to pleading the fifth, that's a right against self-incrimination. You can, I guess you can say, I plead the fifth. I don't think you're going to succeed in somebody saying, okay, you don't have to answer questions. You shouldn't go to court until you've worked out that this has been done in a proper way. Again, patient's consent or a properly signed and worded court order. So those were the two, and now I'm forgetting the third question. So,
and if the judge releases us by court order, are we allowed to testify even if we don't have permission from the client?
Yes, you are. The court order trumps the patient's consent, so you can participate, you can answer questions. But again, before you ever go to court on any kind of document, because we know that counselors get called into these types of situations regularly, check to make sure that it's being done within the accord of our confidentiality statute. But that generally says consent or a court order.
Very good. And on the clinical end, really, it's important to have a discussion with your supervisor. If your agency is large enough and has other resources available, it's really important to have everyone know what your plan is prior to you going to court. So it's really important to do that as well.
Agreed.
Next is with police officers, and so that's a different level. The counselor has gang members on their caseload, and the clients speak to the counselor in confidence. The dilemma is a police officer approaches the counselor and starts by asking questions about one of the clients in the gang. I'm not going to breach confidential information, my client has told me, but where do I draw the line? The counselor needs to know to protect themselves and the agency that they work for.
So first, what I would say is you can't even acknowledge to a police officer somebody's in your program without consent. So start right there in terms of answering questions. And so, I mean, that should end most of these situations. But effectively, and we see it, unfortunately, we do see it, where police will show up to a program and say, we know somebody, this person is here, which, by the way, you can't even acknowledge unless the person's consented, and they want to talk to them. And what you cannot talk to them without the patient's consent. Now, what we advise counselors to do, which is just a variation on this question, though, is to let the person, know who's in the program that the police are here and they're most likely not leaving. What would you like me to do? What I would say on whether you should disclose anything that was given to you confidentially, you should confer with your own supervisory chain, but I would err on the side of not discussing that information without a person's consent being provided for you to do so.
And I think with police officers that are very persistent when they come into your rehab, one of the things I like to do is just provide that police officer a general idea of Title 42, and that we're here to cooperate as much as possible. And I said, I asked them to sit in the waiting room, and then oftentimes we speak with the client, and we feel it's in their best interest to cooperate, although we cannot force them to do so. And then at that point, the client can make the decision to address the issue with the police officer. And if not, then I just go back to the police officer. I have not said whether the person is there or not. Right. I just said we just continue to follow our Title 42 confidentiality laws.
The other thing I would add to that, though, too, is because we've had this situation, thankfully not often, but then the police decide, well, they're just going to walk into the program. What I would say to you is you've done all that you need to do by not acknowledging the person's there if they haven't given you consent to acknowledge them. But if they start to go into your program to, to get to that individual, don't get in their way. You're breaking the law at that point, and you're subject potentially to an arrest. So while we've done our job to protect the person's confidentiality, we have had situations where police are still very insistent, and they will go in and they will find the person if they're there and take them. And once you've gone through the process of checking with the client, getting consent or not getting consent, if you don't get it and they insist on seeing that individual, if you prevent them from seeing that individual, you're now potentially breaking the law and subject to arrest yourself. Now, what I would say is if that happens, you should contact my office because, and I've had this happen once since I've been counsel at the agency, but I have called local law enforcement that did exactly that and had a different kind of conversation explaining to them confidentiality and why our programs do what they do. Thankfully, most law enforcement understand the law and our programs and, work with us to try to, get what they need without us breaking the law.
Okay, thank you. Some other questions regarding confidentiality is having two family members in the same program. And that can provide a lot of problems for the actual operation of the program because the focus then deviates away from the person who's coming in for treatment. Even though it's both of them, their focus needs to be themselves, not each other. And oftentimes programs have policies and procedures that really help provide an opportunity for that individual to select the program that they would like to be treated at, and then their significant other can maybe go to a close by or neighboring program that you work with. But for the most part, we have never found it to be beneficial having two individuals with different needs in the same program. The next question is around confidentiality. However, it's around self-disclosure of recovery status to clients, and do we keep that confidential? And so that's kind of a nice segue for self-disclosure. And self-disclosure is an important topic in dealing with our patients in our treatment settings. Self-disclosure is something that we have used often, and because many of our counselors are in recovery, they often utilize that to establish rapport with our patients. And I think that our stance has been is that self-disclosure really is not the strongest tool in our clinical skill box in establishing rapport with our patients. There are some things that our patients are entitled to know about us, and that is our professional background, our experience in the field, our training and education, our credentials, and the type of therapeutic orientation that we have, if we're a behaviorist, a Gestalt, or that we practice a community self-help. Those are the things that our patients really need to know about ourselves. But oftentimes, establishing rapport, therapeutic alliance with our patient, it isn't always the best mode. The most important aspect with therapeutic alliance is our ability to actively listen to our patients and to actively listen to what they're asking of us, what they need out of treatment, where they're at in their recovery process. And when we take that step in terms of sharing our personal story, we take the focus off the client. The focus then becomes about us. And when we talk about ethics and where it starts to get blurry, that's where that boundary line becomes blurred, and it's very difficult for the patient then to understand where we're coming from, because then we are seen as a possible friend versus a professional in the field of recovery. So it has been at least OASAS's stance and the stance of the ATCs where I'm responsible for, that we limit self-disclosure to a very minimal extent, and that we utilize best practices when it comes to talking to our patients, whether it's using motivational interviewing or cognitive behavioral therapy, or just listening to what they have to say. Our story can be very confusing to them, and they can sometimes misinterpret that. And if they have personality disorders, which many of them do, they already have difficulty sifting out those cues that help them understand what type of relationship that they have with you. So when you say your counselor is asking for your phone number, your counselor or your client is asking for your phone number, or to be Facebook friends, that's where that can get misinterpreted. It's because we have extended ourselves more than we needed to in the therapeutic process.
I'd add to that too, though, which is, so I sit as counsel to the agencies, so I see these situations when they go wrong. Mm-hmm. I mean, I can tell you frequently that the start of an inappropriate relationship or this crossing of boundaries started very innocently, this perception of wanting to help the person, and figuring if I give them my cell phone, they can reach me anytime if they're really in crisis. But what you need to understand, now again, this is a lawyer talking, but the person you're working with in many instances has had issues with relationships in their life. And so now you've changed this relationship from a therapist or counselor or client to a friend. And many times, as I said, when we see cases where we're seeking to discipline a case act, mm-hmm. Or going after an employee in one of our programs, it started very innocently, as you talked about. But then other thing I want to maybe emphasize, and you can reaffirm this, you mentioned that it's against the practice in the ATCs, meaning there are rules, there's policies, correct. There's procedures. So I'm a lawyer, I like policies and procedures, but I can't emphasize enough how important it is if you want to reinforce behaviors of your employees in your program. You need to set the clear rules and then hold people accountable to those rules. So having policies on these kinds of things is important for you, it's for the clients to understand. But so I would strongly encourage on all the kinds of things that we deal with in this, year in ethics training, reduce these things to a policy or a procedure within your program, and then make sure people understand that they're obligated to follow it.
Now, there are some differences with different populations, and the first population is the LGBTQ community. And one of the things that the literature talks about is the fact that many individuals who have different sexual orientation or gender identity are already feeling isolated. They have not necessarily even connected with their family members. And so finding a counselor who is of similar background is more comforting for that patient. And what we find again in the literature is that they will often connect with treatment when they know that their counselor has a similar background. So there are some differences, and there are some references to go to take a look at that population and ensuring that we provide them with the welcoming that they need so that they can access appropriate care.
We're actually working on some guidance related to the LGBTQ community, and because we've heard of circumstances where people did go to treatment and felt very unwelcome, and in fact left treatment and ended up in really bad situations. And I don't know, so now I'll speak as a human. It mystifies me that our system, which works with people who've been written off by almost everybody else, and now add that dimension that we would treat them any differently than we would treat anybody. We're accepting of all. And I mean, beyond that, legally, we have an obligation to provide treatment to them. So, you know, I'd focus more on accepting and welcoming and take them where they're at. However they identify is how we should treat them. And it shouldn't be all that difficult to figure that circumstance out. It's common sense. So just had to add that element for that population.
Thank you. Another population is peers. And now we have a new certification for peers. And their primary role is to talk about their story and specifically provide self-disclosure. And they are much different than someone who is a counselor, professional counselor, who's there to be of guidance and assistance. So the role of the peer is much different. We have an individual who's working very hard in OASAS, Susan Brandow, and she has a lot of information about the role of a peer in our programs, and they provide a vital role. But they do not, and she clearly tells me all the time, they are not just a counselor assistant where they are doing counselor activities. Their role is to provide hope for our patients through their story and also be that ambassador who is a model of recovery and that can help that person maneuver our system and get the necessary resources they need to take care of the problems that they might be having. So the peer has a very unique role in our system, but I think that it's so new, we're still trying to find where they belong and how we can best utilize them.
Yeah, and we're going to be issuing some guidance on that as well. So first off, let me just start with the fact we totally believe in peers and their impact and their ability to engage people who need help. So that's first. But when we set up the certification of the peers, and there's 2 entities right now that can certify, our main concern was around ethics and boundaries. And it's why we set up the training and required work experience. So while we think they're a huge, important part of our system moving forward, there's also concern that they understand their role. And you hit on something which is something we will speak about in the guidance, which is they're not clinical. It's not a clinical person working in a program. What they bring to the table is that lived experience, which seems to have, it helps them connect with people to help them engage in getting better through treatment. So it's really important boundaries to understand, but it's also, again, our concern that somebody with the lived experience who doesn't have a clinical background have some understanding that, again, same kind of thing. They need to understand their relationship as it relates to the person they're trying to help, or to either keep in treatment or to get into treatment. They're not clinical, but they're also not there as a friend. They are there as somebody to help this person understand what it would be like to go through treatment.
Correct. And with self-disclosure now came a full line of questions with regard to the internet and social media. So now we're in a new era where there's Facebook, Instagram, all kinds of things. Our patients then ask for, they ask to be our friend. So, you know, again, I can't emphasize enough around policy and procedure with regard to your agency in terms of how you handle social media. It is important to remember that once you friend somebody, you've changed the relationship. So we're going to still go back to the same principle around the fact is your goal, or your role, I should say, is that of a counselor, a professional counselor helping that individual. You are not really their friend. They need to know that if relapse does occur, they can come back to the program and not be hesitant because of the change in status.
So let me just, I have to say this, so because I see all the bad examples, unfortunately, but the reason we're so stern about this, particularly as it relates to people we credential, and now as we certify as peers, is we see what happens when the boundaries are crossed, our relationships developed. A, they usually end poorly. B, the person many times relapses. So we are, right, we're in this to help people get better. We have too many clear examples when the boundaries are crossed, relationships are developed, they cross the line between, you know, beyond friendship into other things. And when it ends, because they usually do, it ends poorly, and the person ends up relapsing and ends up needing treatment again. And so why we are so strong about this is because we see the experience of the negative impact, the harmful impact it has on people who need help.
One of the ways that I recently found has been effective in terms of staying more anonymous on Facebook, because many of you are still on Facebook, is utilizing your first and middle name only, no last name. And also the picture then becomes something generic or something that you love in your life, whether it's mountains or the streams or whatever, so that it looks more generic to the general public and people can't necessarily look you up or find you. So I think that that's really important to consider if you do have all these types of accounts. That does keep you much more confidential in nature.
But to be clear, don't connect on social media, because we're now seeing that as well in these situations that we run into. They friend each other on Facebook, and it's evidence, by the way, for us. We will use it, and we have. It's just, again, you've crossed the line beyond the therapeutic into a non-therapeutic situation.
We even had one instance because someone stayed in a private messaging system, so they felt it was confidential and it wasn't going to get anywhere. So one thing that did happen was the fact that the person who was upset in the party took pictures of all the conversations, which they can do, and then shared it with the administration of a particular agency. So even if you're in a private message, there you run the risk of someone, as it goes bad, as you say, can share that information to people that you may not want that
Beyond
to
that,
be.
so now I'll speak as the counsel. We have ways of getting a whole bunch of information which we will get and we will use. And one of the first places we look now is social media. So, and texting, and so we have ways of getting the information if we need to.
Moving still a little bit further with that relationship piece, a lot of questions came up around gifts and receipt of gifts from our patients, from a cup of coffee, homemade jam, to something more significant. Do you have any suggestions in terms of policies? The state is very clear about gifts, and so we have a whole ethics committee that reviews things. But I think it's really important that a counselor has a conversation with the patient, saying that it's you know, you don't have to thank me through a gift. You know, we're here to work together on your recovery, and that I feel fine by you just telling me thank you, and that I really appreciate that gift. However, it's something that I can't accept, and move on from there.
But again, and so you've hit on how we handle it with our facilities. I would suggest other providers follow the same practice. Again, you're confusing the relationships, and you're talking about helping people who've had confused at best relationships in their life. Right. So The best thing, I heard a counselor once say, the best thing you can do to thank me is live your life in recovery and stay, you know, stay that way. That'll make me very happy, and that'll be thanks enough.
Our next topic is when is a client not a client? And that was, again, a frequent question that was asked by many individuals out in New York State. And I'm going to read this one so that you can get an idea of where people are struggling with these questions. It says, "It is my view that professionals should never enter a relationship with a former client. However, in reading different disciplines and ethical guidelines, I've noticed that some of them state it's okay after a relationship of 2 years of service. What is OASAS' position in this matter? I would like a more definitive response to accept dual relationships, responding to authorities concerning clients," and it goes on and on and on. But we really want to talk about the fact that is there a guideline in terms of time when a client no longer becomes a client? And I'm going to say OASAS' position is we don't really have a guideline at this point.
We don't. We've had people try to create them, and as far as I'm concerned, they pick an arbitrary number, a year, 2 years. I've heard the 2 years. And I've asked people, so show me the research that says that there's something magical about that time lapse that makes it such that this could not be a harmful situation, and nobody's yet produced it for me. So I asked the writer of the question, anybody else, feel free to bring it to me. What I would say, and this is unfortunately a classic legal lawyer thing, it depends. It really does depend. When we look at these situations, we're looking at, you know, the harm that may have been caused to the individual. So there is no hard and fast rule. I would love to give people guidance, but we've seen situations where it was okay and you know, at a certain point in time. And I really don't want to give time frames because then people try to make that like the benchmark. There is no right time or wrong time. But I would say there's also not a definitive rule that a person can not be a patient for 2 years and then suddenly it's okay to have a relationship with them. I don't want to say that because I could see a situation where that might not be the case. Other thing I want to say as it relates to clients, and something we've seen recently, and so maybe this is more just a broadcast to the field, we get these situations where the person wasn't my client while they were in treatment. So I worked at the program, they were being counseled by another counselor, and then they start a relationship conveniently like within days of the person having left the treatment program. My own view in most of those situations is there was some interaction that occurred during their stay at the program, even though they may not have been the person's client. And same thing, we've seen those situations devolve. You know, people end up relapsing. So we're focused on that as well. So it's not even just when are they your client, it's were you involved with them while they were in the program, but not as their therapist or counselor, and then you started a relationship conveniently in many instances right after they left your program. So I want people to understand, we'll look at those situations as well. It might not fit within the parameters legally of the Justice Center's definition of abuse and neglect, but if you're credentialed by us, we're going to take our own independent look at what occurred, and I can absolutely tell you there have been situations where that happened, and it may not have risen to a high level in the Justice Center, but we did take action against the credential. I can't emphasize it enough. It is so important. You're helping incredibly vulnerable people, many of whom have just limited relationships with people in their lives. Add the addiction. Add, in many instances, a history of abuse and sexual trauma. So we're dealing with incredibly vulnerable people, and they are trusting you when they've come to our system because they're coming voluntarily. And it is critical that you understand and respect that. And helping them, the best way you can help them is not to end up in a relationship with them, but to help them actually figure out how to live a life, you know, in stability and in recovery. So it is something we take very seriously and always will.
And in terms of the clinical aspects where things could be evolving, it's really important that you know, we need to observe things. And when we, you know, listen to a particular incident, what happens is there were signs. There were signs in the program, and no one brought them forward. And it continued to happen. And that's where it's really important to again, be, you know, the person who is going to talk about what's going on, what doesn't look right, and nip it before it actually hurts somebody.
Yeah.
So that's really important, and it kind of takes us to another topic, which is mandated reporting, because many individuals are afraid to report. They're afraid for a lot of different reasons. One being, what if it's wrong? Two, will that defame somebody's character? Will they lose their job because of it? I'm not loyal to my team member. There's all kinds of reasons why people are so hesitant to report, but yet the devastating effects of someone being hurt by someone else is really critical. And as mandated reporters, it is our responsibility to report.
Yeah, so let's start with a couple basics. One is every person who works in an OASAS program, from the Justice Center perspective, so our oversight agency, correct, you are all mandated reporters. No ifs, ands, or buts. You're all mandated reporters, meaning if you see something that you believe was abuse, neglect, a significant incident, you have an obligation to report that to OASAS and the Justice Center. You can't be told by staff or leadership within an agency. You need to run it by them first. Obviously, you should make leadership aware of a situation, but you have an absolute legal obligation to make that report, and you should make that report. So in terms of defaming somebody, I will say from our experience with the Justice Center, we see, you know, complaints all the time. The truth comes out. We find it out. The other thing is, in many programs, ours included, one thing that doesn't lie is the videotape, and many programs have video. Correct. We've used it in many instances to see that something that was alleged to have happened couldn't possibly have happened, and we use that evidence to very quickly resolve the matter. So is the Justice Center. Conversely, we've seen things that we weren't told about happening. And let me just speak as well. If you don't report, you are subject to all the problems that come with if you do report, more so. Failure to report an incident is obstruction in the Justice Center's world, and you've made yourself subject then to a potential abuse and neglect complaint for the failure to report, not even the incident itself. So absolute, you need to make the report. The truth will come out. We take very seriously that people's lives and livelihoods are at stake here. We very quickly work to try to get to the truth, and we don't take lightly when somebody's impacted what that means, but you have to tell us what's going on in your program.
The other piece, when you do know someone's reporting and they came to you as a supervisor or came to you as a colleague, this is what I saw or this is what I know, and I've made the report, it's really important to spend time with that person after they have made the report, because there's a lot of guilt, there's shame, you know, just because they took that step, they felt like a tattletale. They have all these feelings in making that report, and it is our job to make sure that that person's okay. So we should be providing that kind of supervision when we know someone has made a very difficult report. And that's part of that close supervision piece.
There's another dimension which I just have to hit on, which is if you're credentialed by OASAS, you have an independent obligation to report if you know if another credentialed individual or if something happened in a program. So if you don't make a report, you subject yourself to discipline because you fail as a case act, so you could lose your credential or be disciplined on your credential for failure to follow this advice. But to your point, you're absolutely right. There's an emotional aspect of everything. There's an emotional aspect of treatment.
Exactly.
So you can't ever divorce yourself from that, but you also can't divorce yourself from the roles and respecting those roles as you treat people to try to help them get better.
With the onset of managed care, this has brought up a lot of questions with regard to how we provide care, how we continue care, and the reimbursement associated with that. So we received a lot of questions in this area. Many counselors feel that the program administration is collecting money and that the person isn't necessarily needing the treatment at that time. So if the insurance company has 6 months of care, but the person may only need 3, why are we continuing it? And some people feel that that the big interest is collecting as much insurance money as we possibly can. And so there are clinical implications, and I think that there are legal implications when we're not taking a look at medical necessity and the need for care, and that sometimes insurances are limited for that particular year, and that we want to make sure that we're not utilizing the whole benefit just for insurance collection versus what the patient actually needs.
So legally, they can't and shouldn't provide care that's not medically necessary. That's the governing standard. Medicaid managed care, fee-for-service, you name it, self-pay. You shouldn't be treating somebody who's not appropriate medically to be in your program. So in fact, most of the time what I heard was the opposite. That people couldn't get into care, which we've spent a lot of time trying to change. And so medical necessity drives this. To be honest with you, if somebody feels like the program is treating people who don't need to be there, there are avenues to complain about that as well. And we get anonymous complaints and work with the Attorney General's office and other entities when we think programs are providing care just to receive reimbursement and not to get people better and care that's not medically necessary. The other thing I would say, though, too, sort of connected to that, we fund probably 60 to 70% of the programs that we license. Mm-hmm. And if you take our funding as a treatment provider, there's a statutory obligation, legal obligation, that you treat people regardless of their ability to pay. And so if they've exceeded the benefit of their insurance, they no longer have coverage, they have an inability to pay, you can't refuse to treat them because of that aspect, because we've provided funding to cover those gaps. People who don't have insurance, be it they've exhausted their benefit or they'd had no insurance to begin with. So I think there are safeguards and ways to report when we think a program's not doing the right thing clinically for people in their care. Mm-hmm.
The other aspect of reporting is most agencies, if not all, should have a corporate compliance officer where you can make a complaint, anonymous complaint, to your particular agency. But if that isn't available, then they can certainly make an anonymous complaint to OASAS. And one thing I do want to say is that we do follow up on anonymous complaints, and I know that that was one of the issues with some of the questions that we had, that they were afraid of losing their job if they were, quote, the whistleblower.
Well, there's separate protections, which we're not going to get into here about that, but what I would say because I seem to be like the repository of anonymous complaints. They somehow end up on my desk all the time. So let me just let the world understand, just because the person didn't disclose who they are doesn't mean it didn't happen. And in fact, many times what we found is it did indeed happen, and they have reasons, as you said, they're fearful for their job or whatever it might be. We investigate and look into every anonymous complaint.
That's true.
We absolutely have an obligation to. People shouldn't associate the truthfulness of it with the fact that a person refused to identify themselves. And conversely, I've had people complain to me seeking confidentiality, which we will protect people's confidentiality as well. But just so the world understands, it doesn't matter the source. We will look into everything because we have an obligation to. And like I say, many times what we have found is anonymous complaints. Maybe they weren't 100% true, but there was truth within what they wrote. And to be honest, we wouldn't have known about it in some instances without that anonymous complaint. So we do look at all of them that come in.
With that also, there are some programs, and this now goes back to limiting care, where they have asked patients to do certain things in order to get into a treatment program. So in terms of detox, if they're not going to accept a residential program, then we're not going to take them. So they set up these arbitrary conditions that preclude somebody from care. On the clinical aspect, I think it's important to realize that our patients are ambivalent. They're not coming to us necessarily in the active stage of change. And so in helping our patients, we have to work with that ambivalence and utilizing motivational interviewing techniques which help the patient focus in on why they're coming in for care. I think some questions also around what kinds of decisions, how can we make these decisions with our patients? And one model that is identified in the trainings, the ethical trainings, is the shared decision model. The shared decision model is a collaborative approach with the patient where we, again, actively listen to what the client is saying, help them establish some options that they're willing to do and they prefer to do, and then hopefully the third stage is to make a solid decision with regard to what's the best course of action today. And we always don't have to end with the ultimate decision at the end. We can take that next step. What would be the next step in someone's recovery? Maybe not accepting a residential referral, but something different. So these are the things that are really important, and that to just set up arbitrary conditions when our patients take sometimes numerous attempts before they decide to get recovery. And we don't know when that is. So should we set up that condition? It could mean someone's life. And so I think it's really important to, again, we need to be pulling from our clinical tools, our evidence-based practices, our establishing that strong therapeutic alliance with the patient in order to come up with a decision that is not what we want, but what the patient wants.
So I'm not a clinician, but what I can say from having spoken to a lot of people, clinicians in programs, people in recovery, people in program at the time, I've heard things like, I didn't come to this program 100% bought in, and in fact I thought it was a waste, but I decided to go through it for whatever reason. And they talk about reaching a point where they crossed over and it made sense and they bought in. In many people, it's not the first day. In my observation, so I look at this as we've been dealing with a lot of the insurance law stuff we've been working on. A lot of people come with their families, their loved ones, and they're not 100% convinced. That and most people, on my observation, was that they're not totally bought in, but they're closer to buying in than not, which is why we worked really hard to fix the insurance laws to allow them to access the treatment that's appropriate right away. And you work with them, though. It might not be the right place for them to be, but you work with them to find the right place. But you do it while they're getting better, while they're getting help. And you don't make them, for instance, wait in waiting rooms, starting to withdraw or whatever that might be, because they're just as much likely. The other phrase I've heard, which just kills me, it wasn't meant to be. Well, that just can't ever be the answer in our world, especially right now. The drugs people are using right now are lethal. So when we say that, in many instances, we're saying to somebody, you should go continue to use lethal drugs and hopefully you don't die in the process before we can actually get you into care.
Thank you. I also want to go back to when we talked about sexual misconduct, we talked about it coming from the staff. There are instances where our patients come forward to counselors. One may be stating love, some admiration beyond the counseling relationship, and sometimes it becomes much more aggressive, where the patient is threatening to kill themselves or disrobe in front of you or do something pretty aggressive and or threaten the counselor. One of the things that's very important is that we have to remember that we have to set the boundary regardless of what the patient is trying to continue to push at us to get us to connect with them. And so we did have some questions around our patients threatening us in one shape or another. And so there's a lot of fear and there's a lot of issue about transferring that particular person to another counselor's caseload. So there are some arbitrary rules within our treatment settings that place our counselors in an uncomfortable position with a patient who cannot control their emotions and becomes more aggressive, either wanting some sort of connection with a relationship or threatening, to hurt the individual.
Yeah, well, again, as a lawyer, let your leadership, let your supervisor, let other counselors know what's going on. That's the best approach to take in those circumstances. And it might be not even that they should work with another counselor in that program. It might be you need to find them another program.
Exactly.
What I would implore you, though, is don't kick them out of the program. Too much you hear that somebody's asked to leave. Well, if you're asking them to leave, our expectation is you're finding them the place to go to. And don't let them leave before you found that place. But the worst thing you can do is not talk about this stuff. And it sort of leads or speaks to another issue, which I think is critical. I think it's important for our programs to have a supervisory foundation, a place where counselors who are starting to go down this road, I want to give them my cell phone number, they need to have that ability to talk to someone to help them sort of sort out the fact that it's not okay, and it's okay that you're telling us about this and we'll do something about it. But yeah, on the patient piece, yeah, and we've said this a lot, our patients are not as vulnerable as the patients in OMH and OPWDD situations. They have their issues as well. But the worst thing you can do is to just ignore it, not disclose it to others. What I would say, though, again, re-emphasize, please don't kick people out because of that. Find them a different place or a different counselor.
And we have found that to be very true within the ATCs. We have an opportunity to deflect to another ATC when it's not working at a particular site. And we have found it was beneficial for the patient, and they were able to maintain their recovery, and whatever transference or countertransference occurred at the previous program was the fresh start was helpful.
Great.
One of the things that I would like to do is talk about some best practices, because I think in providing an environment, an ethical environment, it's really important to deal with this on an everyday basis. The luxury of being able to develop a lot of the trainings for the year in ethics has really, I'm starting to feel like I've dealt with and understood through literature and readings and the book that I had shared with you earlier in the presentation, that ethics should be part of your culture in the program. So I can't emphasize that enough, and if that is true, then your staff will ask questions to their supervisors will, again, bring things to administration, and hopefully it's an open opportunity for individuals to feel comfortable in the programs. So really, the first thing is to support your code of ethics and post them. All disciplines have a code of ethics. For Nurses Day, we gave the nurses their poster of ethics from the ANA. There's the canon of ethics for CASACs. Social workers have them, medical profession as well. So having them posted is also, it's helpful for patients to understand what we're being held to, as well as them being more likely to report something if they know it's not right. Also, to offer ongoing education. It's really important for programs to take advantage of Learning Thursdays, set up your own ethics committee where you can have staff members bring questions and you can research them through the literature. You want to create an environment where staff can speak up, so that you have all staff meetings or multidisciplinary meetings where there's a lot of robust conversation and things can kind of, before they are a problem, get nipped in the bud. Also, identify somebody on your team who will be the ethics expert so that they can take on that role. It's also important to have EAP services. If not EAP services, a place where employees can get care, because as we all know, we're all humans. We all have vulnerabilities. We are not immune to depression, anxiety, grief and loss issues, trauma. And so sometimes we need help beyond what we can sometimes offer ourselves. And our agency should support counselor wellness and have counselor wellness activities that individuals can do to take care of themselves. Because I think what we have found is that when our staff are under stress, they tend to, or they're not well, they tend to cross boundaries and end up in areas where there's misconduct. So I really wanted to have an opportunity to state those best practices, because those are opportunities, proactive opportunities, that your program can get involved with. I want to thank you for an opportunity to speak with you today on ethical dilemmas. I want to thank Rob for being here to provide a lot of information that was very valuable. You can ask questions by contacting us on the Learning Thursday email address at the end of this presentation. Thank you very much.
Thanks.
Thank you, Maria and Rob. That was a very rich and comprehensive discussion. If you have any questions, you can certainly feel free to reach out to Rob or Maria. Their contact information is on the slide. Again, you can always direct questions to learningthurs@oasas.ny.gov. And also, after you're done watching this presentation and after you've taken the exam, we hope that you will take a few more moments to complete our survey. Your feedback is very important to us. Thank you very much and have a wonderful day.